Good evening, everybody, and welcome to the first Daily Maverick webinar of 2021. Thank you very much for joining us. I have to say at the outset that today is a sad and a dark day in South Africa, and I want just to start, or before we start the heart of this webinar, to remember all of those who have died of COVID-19, and in particular today, the 3 doctors who died in a helicopter crash in KwaZulu-Natal together with the 2 pilots. Their names were Dr. Rudolph Mononyane, Dr. Sia Mahlangu, and Sister Mpho Gaba, as well as the minister in the presidency, Jackson Mthembu, as well as many other friends, acquaintances, family members, all totaling probably by the end of today over 39 deaths officially linked to COVID-19 in our country. So it is a dark time. It's a time for courage and resilience and for supporting our healthcare workers, but it's also a time for rallying to try to defeat this pandemic. And I think that makes the subject of this evening, which is COVID-19 vaccines, all the more urgent and more important. And we're very privileged to that end to be joined this evening by 2 people from South Africa who are not just leaders in vaccine science in South Africa, but who are world-class scientists in the fields of medicine and vaccine. I think they're probably by now known to most of the people who are with us, but I still will introduce them. I'll start with Dr. Glenda Gray. She's on my right. Glenda, good evening, and thank you for joining us. Glenda is a pediatrician. She's the president of the Medical Research Council. She is responsible for progress that we made in HIV around mother-to-child HIV transmission many years ago, 2 decades almost ago. And relevant to tonight's discussion, she's the principal investigator of one of the vaccine trials currently taking place in South Africa, the Johnson & Johnson vaccine trial, which I believe, Glenda, is due to come up with some results any day now. But thank you, Glenda, for being with us. The second scientist to join us to answer your questions, also well known to you, Professor Shabir Madhi. Professor Madhi has just started his tenure as Dean of the Faculty of Health Sciences at Wits University. He's a vaccinologist by trade. Something I didn't know until 3 minutes ago is that he is the scientist responsible for bringing the pneumococcal vaccine to South Africa in 2009, or which we started a program in 2009, recognized by the World Health Organization, that has benefited hundreds of thousands of children's lives. So with very direct experience in programming vaccines as well as researching vaccines. And the last thing I would say about Professor Madhi is that he's the principal investigator of the what's known as the Oxford trial or the AstraZeneca trial, which too, I believe, is going to publish some results probably by the end of this month. So Professor Madhi, thank you for making time to be with us this evening. Before I get into the substance, I also just want to thank you, the audience who joined us tonight. We had 2,200 registrations. As importantly, we had over 100 questions sent in advance of tonight's webinar, very useful, informed questions. And so what we're going to try to do is to structure much of the discussion around questions that you have already submitted, although of course I will keep an eye on the chat line. So just to kick off, I'm going to start by asking first Shabir and then Glenda to just spend 3 or 5 minutes talking to us about where you think we have reached with vaccines in South Africa. What are perhaps the critical make or break issues with a vaccine program in the months ahead. And can you also just lay a little bit of a foundation for some of us? We hear about mRNA, we hear about protein vaccines, viral vector, we hear about efficacy, we hear about immunity, herd immunity. I don't expect you to deal with all of that in 5 minutes, but can you at least take these introductory remarks to try and to build the foundation? After we've heard from Professor Madhi and Professor Gray, we will move into the questions that we have been asked, which will start with just aspects of basic science to do with vaccines that concern those of you who are with us tonight. So, Professor Madhi, thank you. I'm now handing over to you.
So thanks, Mark, and good evening to all of the listeners. So what I'm going to do is just sort of provide a landscape in terms of the 4 different technologies that have been used to develop COVID-19 vaccines. 2 of these technologies are relatively new. One is completely novel, and the other 2 are sort of using a more tried and tested approach in the development of vaccines. So to start off with, the 2 that are relatively new and the one that is completely novel in the field of infectious diseases is what is known as the nucleotide-based vaccines, and that's more commonly currently known as the messenger RNA-based vaccines. And then you've got your vector-based vaccines. The vector-based vaccines have now a precedent in terms of having been developed and specifically against Ebola. Now, although these are 2 different technologies, they sort of using the same sort of approach in trying to get the immune system stimulated against a very critical component of the virus, which we believe is important for that virus to attach to the human cell. And the way that these 2 different technologies work is that they deliver the genetic material that codes for what is known as a spike protein. Now, the spike protein is extremely important in terms of being able for the virus to be able to attach to the cells. So that genetic material is delivered either directly as messenger RNA, or that genetic material has been inserted into what we call a vector, which is usually a virus that doesn't cause illness in humans. And often these vectors are actually inactivated, so they can't actually replicate once they're administered. So once that is injected into an individual, what essentially would happen is that that RNA will be released into the muscle cell usually. The RNA is then read. It provides sort of the blueprint for the cell to start producing protein. Now, importantly, this RNA does not integrate into the DNA. It does not enter into the nucleus of the cell, which is where the DNA is. So it's impossible for this RNA to sort of alter the DNA of an individual. And I think that's really important to emphasize. And because this is not live virus, it doesn't have other enzymes that will allow it to be able to undertake such an integration. So once this protein is produced using the cell itself, that protein is expressed to the immune system. And then you've got 2 different types of responses, what we call B-cell immunity, where we have antibodies. These antibodies are sort of protein molecules that circulate in the blood. And as soon as it comes into contact with a virus, or as soon as it comes into contact with a virus, it will sort of prevent it, right? It will attach to the virus and prevent the virus from infecting the cells. Now, the other 2 approaches, so the vaccines that are using this particular technology, as you know, is a Pfizer vaccine and a Moderna vaccine are using the messenger RNA-based vaccines. And then the vector-based vaccines are, as an example, the AstraZeneca or the University of Oxford and the J&J vaccines. So these are the 2 different technologies. Now, these are relatively new. The messenger RNA-based technology has been used previously for almost the past decade in terms of trying to develop vaccines against cancer. Now, the more tried and tested approaches is where we actually take the protein itself and actually inject that in an individual, and that is what we call a protein-based vaccine. The vaccine that is furthest down the line, in fact, is also one of the 2 studies that we're leading in our research unit is the Novavax vaccine. So this is a protein-based vaccine. It uses a more tried and tested approach in terms of delivering the protein to the immune system to get the immune system to respond. And then the last one is your virus-based vaccine. So these are vaccines where they're actually using the virus itself, the SARS-CoV-2 virus. They're either attenuating it or inactivating it. The attenuated vaccines haven't really moved that far in terms of development. But the inactivated vaccines, as an example, the vaccine that's been developed by Sinopharm, is an example. There's a Chinese company. It's an example of an inactivated vaccine. Examples of inactivated vaccines are when people get the polio vaccine as an injection. That's an example of an inactivated vaccine. Examples of the protein-based vaccines are the vaccines that we use against whooping cough or against pertussis and diphtheria. So those are sort of more tried and tested approaches. So that is just where we are. Now, what we need to understand, currently there's more than 40 different vaccines that are in human trials, including 5 that have now been authorized for use by different regulatory authorities. And the ones that have been authorized for use are the Moderna vaccine, the Pfizer vaccine, the AstraZeneca vaccine, and then there's a Chinese vaccine, which is an inactivated vaccine, Sinopharm, where the efficacy of that vaccine is in the region of about 50%, and the Russian vaccine, which is also a vector-based vaccine, similar to the one that Johnson & Johnson is developing, although it's got 2 different vectors included.
Thank you very much, Professor Madhi. I'm going to move straight on to Professor Glenda Gray to pick up where Professor Madhi left off and just make some introductory comments. Thanks, Professor Gray.
So thanks Shabir, for painting the scene. So how do we know these vaccines work, and how do we determine how effective they are? So I think when we do vaccine trials, we ask a certain amount of questions. So before we can go into efficacy studies, we have to know that the vaccine is safe and that it has a good immune response. And Shabir mentioned that we look at both parts of the immune system, both the B cells and the T cells. We look at binding antibodies and we look at neutralizing antibodies. And we also look at other non-neutralizing activities or antiviral activities that the vaccine may induce. So when we get into efficacy, we ask 3 questions. We ask, does this vaccine decrease the acquisition of infection? So does this vaccine prevent infection in the individual who was vaccinated? The second question we ask is, if you do get the infection, does this vaccine decrease the frequency and the severity of the disease? Does it stop you from going into ICU? Does it stop you from going into hospital? And the third question, which is very important, is, does the vaccine reduce transmission in the community? And that's important because obviously we want to make sure that the vaccines that we use will be able to decrease transmission in the community. And so there are lots of different benefits of a vaccine. There's the individual benefit. So the person who gets the vaccine will be protected from getting the disease or the infection, and will be protected from going into ICU or from dying. So that's the individual person. The individual who takes the vaccine will be protected, and they will have an individual health benefit. There's also public health benefits, and we give vaccines because we want to control the epidemic. And the only way you're able to control an epidemic is through vaccines. And so we use vaccines for public health benefit to try and prevent communities getting infection, and that's why we try and attain herd immunity by using vaccination. So that's the public health approach. By vaccinating lots of people, you also improve the public health of the country because you reduce hospitalizations, you reduce ICU admissions, and you ease the burden of the disease in the hospitals. And so you create space for healthcare workers to do the other jobs. There are also economic importance of a vaccine. So why does a vaccine improve the economic status of a country? If we can immunize the workforce and we can protect the workforce from being ill, we can start to open up the economy. So a vaccine also has economical benefits. It also has scholastic or academic benefits, because if we can get our children back to school, get our students into university, we can protect the education system, the academic year, and we can also have an impact on the future economy of our country. So vaccination helps the individual, it helps the public health, and it also helps the economy. And it also helps us to keep our country going. So how do we know that these vaccines work? So Shabir mentioned the vaccines that have already been registered. So when a company wants to register a vaccine, they have to present to the regulatory authority evidence that this vaccine works. And we've seen from the trials is that these vaccines have worked irrespective of age, irrespective of sex, and irrespective of ethnicity. These vaccines have worked in hypertension, They've worked in diabetes. They prevented people with obesity from getting severe illness. They've worked in people with chronic lung disease, with people with cardiovascular disease, people with malignancy or cancers, and they've worked with people who have either got comorbidities or don't have comorbidities. They work with people who have kidney disease. So we've seen great evidence that these vaccines work with comorbidities, without, and they work in all age groups. And they work quite spectacularly. We've seen in the Moderna and the Pfizer study, which is the mRNA, that these vaccines are 90% to 95% efficacious, which means if you compare the people who got the vaccine who had kidney disease and the people who didn't get the vaccine who got kidney disease, there's a much less frequency of people getting COVID in that group, and it goes on with all the comorbidities. So what we've seen is that vaccinations will save people's lives, and it will help the economy, the individual, and the health system. We do need to assess the impact of the vaccines on ongoing transmission, and we have evidence that that there is probably an impact on ongoing transmission, because we do know that the vaccines work in asymptomatic individuals. And by working in asymptomatic individuals, they reduce the viral load and probably make people less infectious and then less likely to transmit the virus. As we move along, as we roll out these vaccines, we will start to get evidence of this. And I think already in Israel, we're starting to see evidence of the impact of the vaccination program on controlling transmission in the community. I think I should stop there. And I just wanted to make the point before I end, is that we've had about 300 days of the COVID pandemic in South Africa, and during this time we have lost 83,000 people since the beginning of the pandemic, and that is a lot of people. Although we've reported much less directly from COVID cases, we have a total amount of 83,000 deaths that are probably both COVID and non-COVID related. And so this has been a devastating year for our country, and we've lost so many lives. And so there is an urgent need to start vaccinating people so we can continue to save lives in South Africa. I think I should stop there, and maybe you can ask us some more specific questions so that we can with the concerns that the viewers have.
Thank you very much, Glenda, and thank you, Shabir, and thanks for keeping to time. I think you've already started to answer some of the questions that have been asked. There are many questions, and I want to tell people who are watching tonight, we won't get to them all, unfortunately, but Glenda and Shabir have seen all of the questions, and what we're going to try to do is answer in writing every single question, because we recognize the importance of every single question. What I've done is to group the questions we've received and the questions that I'm seeing at the moment under basic science, under the fears that people are expressing about vaccines, under issues of who's included, who's excluded, who might be contraindicated, and then a bunch of political questions that many of you are asking. So I'm going to start with questions that have been asked just about the basic science. And Glenda and Shabir, you can pick and choose from these. One of the questions was, is immunity from vaccines weaker than immunity from actually being infected with COVID-19? And do you know how long vaccine-induced immunity will last for? Linked to that as well, do people who've already had COVID-19 need to be receive a vaccine? And in fact, somebody asked the question, if I was on the trial, on one of your trials, should I be vaccinated, because I don't know if I was on a placebo or whether I was on the active ingredient. Why can't we manufacture vaccines in South Africa? And can you be revaccinated with a better vaccine? We've heard you both talk about efficacy, and we hear talk about 90% efficacy versus 70% efficacy and so on. Can you be revaccinated? And the last in this group, what vaccine will we be getting in South Africa? Shabir, I'm going to ask you to kick off with some of those questions.
Okay, so thanks. So I'll start off with the issue in terms of the differences between immunity that's induced by vaccine and natural-induced immunity, the duration. So what we do currently understand in terms of natural-induced immunity is that in absence of the emergence of a variant, such as we're experiencing currently in South Africa, natural-induced immunity lasts for at least 9 months. But the reason why we're only saying 9 months up to now is because most of the studies have only evaluated for up to 9 months. If we base it on experience with other coronaviruses, including the MERS virus and the SARS virus, natural immunity probably lasts for at least 2 to 3 years. Now, when it comes to vaccine-induced immunity, obviously right now, it's difficult to estimate exactly what the duration of protection is going to be. But the difference between vaccine-induced immunity and natural infection is vaccines generally will result in a much more predictable immune response than that would occur with natural infection. So as an example, with natural infection, there's huge variability between individuals depending on the severity of illness. So individuals that end up with more severe disease have a much more robust antibody response, a much more robust lymphocyte response than individuals that end up with mild infection or asymptomatic infection. So when we look at these vaccines, what were done initially is in terms of evaluating the immune responses that was induced by vaccines, is they compared it to what we call convalescent sera. So that is the immune response that was induced in the individuals with natural infection. And what they showed is that for almost all of the vaccines, especially after the second dose of vaccine, after the booster dose, the immune responses that were being induced was similar, but mostly better than what was being induced after mild and moderate infection, and probably for most of the vaccines on par to what was being induced in individuals with severe disease. So the short answer is that vaccines really are designed to result in a much more predictable immune response. It also induces memory responses, which also occur with natural infection, and that's very important when it comes to the duration of immunity. It's whether these vaccines, in addition to inducing antibody in the short term, are also able to induce these memory cells, which is what we really depend on at the end of the day, that should we become re-exposed to the pathogen, to the virus at the future stage, they can rapidly recruit those sort of cells that have been primed to respond much quicker than the first time round when you get these vaccines. So duration of protection for vaccines unknown. I would estimate that we probably would look at a 2 to 3 year period as well, at least. But a big unknown, and I have to emphasize this unfortunately, is how these vaccines are going to work specifically against the variant that has now emerged in South Africa and in Brazil.
Thank you, Shabir. And this question of how we deal with the variant is something that we're going to come to in a few minutes to assure everybody, because it is a big question on everybody's mind. But Glenda, would you like to pick up on some of that first set of questions?
Sure. So the people who've been involved in vaccine research will either have received the active vaccination or the placebo. And if there is a vaccine that's coming into the country, so I'll just explain to you what's happened in the US. So people that have been involved in vaccine trials, and they have either opted to become unblinded, so that the study staff can tell them that you got the placebo or the vaccine. And once they know what arm they were on the study, they can then choose not to get vaccinated, or they can choose to get vaccinated if they had the placebo. There are a lot of people that actually got the active vaccination that have actually also chosen to get another vaccination, which is very interesting, because what we call a heterologous prime boost approach, which is actually a very good approach. And what we have seen in those individuals is anecdotally is that they have had quite a great immune response to the third vaccination, which is probably good. It's probably a good thing. It's very important to follow up people that have had what we call heterologous prime boost approaches, because we want to have long-term safety on these participants who've had 2 different kinds of vaccine approaches. So there are choices for people who've been on trials, and they could continue to receive the study vaccination that they wouldn't have got if they were on placebo, and follow up. In terms of being revaccinated, it's very important that we follow up all the participants who've been on trials, because we do know the short-term potency or the short-term efficacy, and we do know the short-term durability, but we don't know how long these vaccines last for and how durable they are. And so it's important to follow up people on vaccine trials because they give us information on how the immune response is waning and give us information about when to time the boost. So we do believe, as Shabir says, is that these vaccines will wane in durability, and we will need to time a boost at some stage or the other, and that's why it's important to continue to follow yourself in the vaccine trial so we can see how your immune response is doing. So we do believe that some of the vaccines, particularly maybe the single-dose vaccines like the J&J one, we'll be watching the durability, and we may need to discuss issues around boost later on in the duration of the study. What vaccine are we should you get, or what vaccine are we going to get? I think we've been very lucky to see that both the AZ or chimp adeno vaccine plus the Moderna and Pfizer have all shown great efficacy. And I think at this stage, all three of those vaccine choices for South Africa would be great. And I think that we would like to see all of them come into South Africa. I'd also like to, if the J&J study works, I would like to see that vaccine being introduced because it's an emergency vaccine. It's a single dose vaccine, and its indication is for emergency use. So it's to protect the healthcare worker or the individual, and it may need a top up or a boost at a later stage. And J&J is also evaluating the 2-dose vaccine. So for South Africa, I think that we would like to see as many vaccines come in, and we would like to evaluate the rollout of the vaccines that come in to make sure that we understand the long-term safety of all of these vaccines. Shabir mentioned, and you also, Mark, mentioned the variant. And the important thing about the variant is that there had been very little evolution in the receptor binding domain of the virus until recently, until kind of mid-year. And then we start to see the receptor binding domains mutations start to spread. And maybe the ones that are the most interesting are the ones that we've seen in the UK, in South Africa, and in Brazil, which may affect the receptor binding domain, which is important for vaccine efficacy. So the question of vaccine efficacy is very important, and we are studying that at the moment. And so all the vaccine trials that we're involved in, we are looking at breakthrough infections. We're doing genetic sequencing of all the viruses that have broken through in the trial. We're also evaluating the samples to see if there's a reduction in vaccine efficacy. And so we'll be able to tell you as soon whether there was a difference in vaccine efficacy between South Africa, Brazil, and Latin America, and the United States. So we have enough people enrolled in all parts of the world to be able to really look at the impact of these variants on vaccine efficacy. And we're going to know those results in the next couple of weeks.
Thank you very much, Glenda. I'm going to move us on, but just before I do that, just a very basic question, but I think it'll help people. If you talk about 90% vaccine efficacy, are you basically saying that in 9 out of 10 of the people who received the active vaccine, you got protection? And 70%, 7 out of... We hear this 90%, 70% thrown around. It's just simply as possible and quickly as possible explain that. And similarly, I just saw a question from Wendy Orr saying, in our choice of vaccines, how can we use something like the Pfizer vaccine that has to be stored at, I think, minus 80 degrees centigrade? As quick as possible, because I want to get on to some of the fears and worries that people are expressing.
So, Mark, when we talk of something like 90% efficacy, imagine there's 2 groups of 100 each. One group has received a vaccine, the other group has received a placebo. In the one group, in the placebo group, if there's 10 cases, and in a vaccine group, there's 1 case, that calculation comes up to 90% efficacy. So basically, it's sort of the risk reduction between the 2 groups in terms of developing COVID-19. So that is that part. And Mark, just briefly to cut into 2 other things, I think the point that Wendy makes is completely correct. The Pfizer type of vaccine is not one that can be deployed at scale, but it is a vaccine that possibly could be used as an example in healthcare settings, especially healthcare settings that are close by to academic centers where these sort of facilities exist to store those vaccines. But it would be a very niche type of a market in a South African context, and it wouldn't be deployable beyond that. Two quick other answers. If someone has had COVID before, should they be vaccinated? The short answer is yes, they probably should be vaccinated. And the WHO indicates that you shouldn't base vaccination based on whether you've been previously infected or not. And then I think the other issue was the manufacturing issue. Unfortunately, South Africa hasn't manufactured a vaccine since the year 2000. To develop a manufacturing facility from scratch, and I'm not talking of full and finish, which is what is being done as an example for the J&J vaccine, but to be able to develop a manufacturing facility from scratch will probably take a good 3 to 5 years for that to actually work and start producing vaccines in the millions of doses. So right now, unfortunately, because of the lack of investment, both in the private sector as well as government and in academia, we're simply not in a position that Brazil and India are in, where those sort of facilities have been established over decades.
Thank you.
That's a great point, Mark, just quickly about the respiration. So I think it's very important that although the current version of the mRNA that Pfizer is making requires a -70 refrigeration, the beauty about vaccine research is once you know a vaccine works, you strive for innovation, and your next aim is to make your vaccine stable at better temperatures. And just to remind you that the Moderna is also an mRNA that doesn't require the extreme refrigeration that Pfizer. And so I would imagine over the next couple of weeks, you would see innovation in the issue around the storing of vaccines like the Pfizer. So just because the first generation requires -70, it doesn't mean that the second and third generation will require that. And that will be a huge, if Pfizer wants to market their vaccine at a global level, that's an innovation challenge they're going to have to overcome very rapidly.
Yeah, and just very quickly to add, because I saw two questions about what's happening with Aspen Pharmacare in PE. Aspen is not manufacturing the vaccines. They're doing what Shabir called filling and finishing the vaccines and then re-exporting them. That's perhaps another issue for another day, but they're not manufacturing the vaccines from scratch, as I understand it. Correct, Shabir, and correct, Glenda? Okay. Yeah. Time is ticking, and I want us to move on. There's a lot of fears and uncertainties that people express about the vaccines. And so we have a number of questions. These vaccines have been very rapidly developed and rapidly approved. Are they safe? Does that mean that corners have been cut? Then somebody else asked, how do we assess, given the short term in which they've been developed, how do we assess long-term safety of these vaccines? And then, of course, the big question that many people have asked is, are they effective against further mutations and the variants that we've seen emerge in this country and in other parts of the world? So can we take a few minutes to try to answer those questions before I'm going to move after that onto issues of who's in and who's out and who should and who shouldn't and so on. Who wants to?
I'll talk about safety. So as Shabir mentioned, a lot of these platforms that have been used in other vaccination approaches. And the chimp ad and the ad26 have been used in Zika and Ebola and malaria. And so we have hundreds of thousands of people that have received these kind of vaccines. So we know that we know how the vector platform works, and we know the safety profile of the viral vector platform. And what we're evaluating is the new immunogen that's been inserted into these well-known and tested platforms. And so we do know the safety of the platform, and we're evaluating the safety of the platform with a new immunogen. And we know the short-term safety, and obviously what's important is also to know what the long-term safety is. And that's why it's important to continue to follow up the participants in these trials so that we can get long-term readouts on the safety. Once the regulators are happy with the short-term efficacy and safety, they will register it under a certain registration. And it'll be in these certain registrations, it is required that during the rollout process, data is accumulated on both the efficacy and the the safety, and this is called pharmacovigilance. And so we evaluate the long-term safety in the rollout situation. And that's very important because we obviously need to know what the long-term safety is. And so that will be an ongoing process for us. And that's critical in all parts of the world to follow up both participants and also to follow up people who have been vaccinated. As the variants, so obviously everybody is very interested in the variants. And as we speak, every breakthrough infection in any vaccine trial, whether it's been rolled out or whether it's in a study, sequencing of these variants will happen. And obviously, the idea is if these variants start to mutate to such an extent that there's impact on the vaccine efficacy, these vaccines will be modified to address the circulating variant that is circulating at the stage. If it doesn't, if that circulating variant isn't, the vaccine is not effective against the circulating variant. So even as we speak now, the Moderna and Pfizer are looking into this, and they've indicated that they are able to modify their vaccine to adapt to the circulating strains.
Thank you, Glenda. Shabir.
Yeah, so just to add to Glenda, in terms of safety, so these vaccines, many of these vaccines have now been evaluated in tens of thousands of people, up to 30,000, 40,000 of people. And to be able to determine whether the vaccine is actually effective, prevents COVID-19, you can do a study which is much smaller in terms of the sample size, maybe up to 5,000. And one of the main reasons for this enrolling large number of individuals is really to address the issue of safety. And safety is of foremost concern before a vaccine is actually authorized for use. But granted, what is lacking is long-term safety data, but that is only going to come by as we start rolling out these vaccines. We can't be in a situation that we wait 5 years to get long-term safety data, by which time the pandemic would have passed and the number of lives that would be lost would be in the hundreds of millions, let alone in the millions. So there's an urgency. Now, the other thing that has expedited the development of these vaccines is that often what happens is that there's different stages of development which take place in series. And there's usually a pause between those different stages. What's happened with COVID-19 is what is known as phase 1, phase 2, phase 3. All of those have pretty much taken place almost in parallel, or they've been initiated almost immediately after the other phase has stopped. And usually that sort of spacing out of the different phases is about 2 to 3 years in terms of the vaccine development. Now, the reason why this has been able to take place in parallel is that companies have been much more generous in terms of taking on the risk of failure. So usually you want to have some confidence that your vaccine has proof of concept before going to large studies. But this time around, companies have simply gone forward risking failure in huge trials, which is something that they generally try to avoid. Now, in terms of the variant, I think for me the most important issue right now, and so the South African variant and the Brazilian variant are different from the variant in the UK. The similarity is that they've got a same mutation that makes it more transmissible, at least about 50% more transmissible than earlier versions of the virus that were circulating, which means that it's much more infectious. But the difference in the South African variant compared to the UK variant is that there's some additional mutations in what Glenda was referring to as a receptor binding domain. And those are what we consider to be immunodominant parts of the virus, in that we're wanting antibody to be produced against that part of the virus, which will be able to neutralize the activity of the virus. Unfortunately, with the mutations that have taken place, what has been shown by Penny Moore at the NICD is that when tested against the serum of individuals that have recovered from past infection, the potency of that antibody is greatly diminished against the variant that's circulating. Now, we need to guard against extrapolating. That means that the vaccines will also not work against the variant. Right now, we don't know. Remember, we spoke earlier that when looking at immune responses that's induced by vaccine, it's both antibody-mediated as well as your cytotoxic T lymphocytes. So right now, we haven't done experiments to see whether this variant is any less sensitive to these T lymphocyte immune responses. In addition to which, the repertoire of immune response that's induced by vaccine is very, very different to the repertoire of immune response that's induced by natural infection. So there's a number of unknowns, and it would be reckless to extrapolate that based on what we've observed in individuals that have recovered from COVID-19, whose antibodies seems to be less effective in neutralizing the activity of this virus, that the same thing would apply for vaccines. Glenda mentioned that we're probably going to provide the most important information globally from the vaccine trials that we'll be reporting in the space of the next few days, if not the next 1 or 2 weeks, as to whether COVID-19 vaccines work against this variant. And the results from these studies is not just going to have implications for South Africa. The results from these studies are going to have global implications in terms of the future development and rollout of COVID-19 vaccines.
Thank you, Shabir. That's very, very important news to hear about the role that South Africa is going to play. Is it correct to say, and I don't want a long answer to this though, that the faster we roll out vaccines and reach herd immunity, the greater chance we have of slowing mutations and having COVID-19 with us in an uncontrollable fashion for many years to come? Is that right?
Absolutely. And one of the main reasons why this variant has probably emerged in South Africa is the first time round we had a high force of infection. A large percentage of the population became infected. And the virus, to be able to survive, needs to somehow evade that immune response that's been induced against it. And part of the way it evades it is basically to undergo mutations. So this is what we call immune evasion. So the virus is adapting itself to what it's been exposed and what is challenging its survival. So to get rid of that, to prevent that from happening, you want to get huge number of people immune over a short period of time so that you don't have this type of immune evasion that emerges if there's a lot of virus that's circulating.
Thank you. And a couple of other questions that people are asking, just to nail this section quickly. Nika Refali asks, Salim Abdul Karim said at the start of the week that most adverse events or reactions happen very short term after vaccination. Would you both agree that that is correct?
Yeah, I think he was referring to the after vaccination, your arm can be sore, you can mimic, you can get flu-like illness, mild temperatures, and so those are the most common side effects. And they normally, it is true, so those normally would result in the first few days after vaccination, and very rarely after weeks of vaccination. So usually we have a good handle on the short-term safety, and the short-term safety normally reflects the long-term safety as well.
Thank you very much. And that's common to many vaccines, Glenda, isn't it? These type of side effects. And then another thing I just want to quickly nail down, a couple of people have questioned, okay, why are we looking at vaccines with 70% efficacy if we can have 90%? And if a vaccine comes along with 50% efficacy, is it still useful? Glenda, will you take that as well, and as quickly as you can?
Sure. I think the most important thing is coverage. So it's no use having a 90% efficacious vaccine that you only have 10% coverage on. And so we in HIV vaccine research, we estimated that we could even control and help control the HIV epidemic with a vaccine that was between 30 and 50% efficacious if we had good coverage. And so you could have a vaccine that had 50% coverage, 50% efficacy and whole community coverage, and you would get herd immunity and control of the virus. So it's all about coverage. Efficacy and coverage are important, and it's important to get the vaccine out. And the more coverage you get, the more public health benefits you'll get, irrespective of how effective the vaccine is.
Thank you very much. I'm moving on now to these questions of what you call inclusion, exclusion, which bother a lot of people. Some of the questions we're getting are why not children included in the rollout? Are the vaccines safe for children? Would the vaccines... Just 1 second, Glenda, I'm going to throw a few at you. Would the vaccines be safe for people living with HIV? Are there particular comorbidities or people who are on long-term treatment for chronic diseases who shouldn't get the vaccines? And then a big one for me, it's a political question, but an important question. Government has been very silent on undocumented migrants and refugees, i.e. leaving some parts of the population out of vaccine coverage. Do you think that's a sensible thing to do? What would be your position on that? So, Glenda, you were wanting to jump in. You first, and then on to Shabir.
I'll talk about the children. So obviously, the first thing is to establish safety and efficacy in adults. And once you establish safety and efficacy in adults, you go down and establish the safety and immunogenicity in children and babies. And once these are done, you can move into those age groups. And so as we speak, there are vaccine trials happening at a global level in children, because obviously immunizing children will help us keep schools open, and immunizing young adults will help us keep universities open. So children are imperative, and once the safety and immunogenicity has been established, they will become beneficiaries of a vaccine program, and are very important to control the epidemic very important to control the epidemic. Pregnant women are also very important. A lot of our healthcare workers are pregnant women, and they look after COVID-19 patients. And so we do have to rapidly establish safety in women and pregnant women, and to be able to immunize them. There are some programs and some regulators that will allow the use of these vaccines in pregnant women, and I guess that's a discussion that the regulator has to have and decide on the risk-benefit profile of that. The comorbidities is important. If these vaccines don't work in sick and old people, then we are not going to make an impact on the individual benefits of these vaccines. And we've seen that these vaccines actually do work on people with lots of comorbidities and the elderly, and that's imperative, and that's the individual health benefits of these vaccines. And in terms of the issue around everybody who lives in this country, irrespective of whether they are a South African citizen, have an ID, have a passport, if they're illegal or legal, everyone in this country deserves access to a life-saving vaccination process, and are integral in managing and controlling the epidemic in our country.
Thank you, Glenda. Not only deserves access, but has a constitutional right to have access as well. Shabir.
Yeah, I'll just pick up on the last point that Glenda mentioned, and that is from a public health perspective. If you're really trying to get a sufficient proportion of the population immune to bring about an interruption in terms of the chain of transmission of the virus, which is otherwise referred to herd immunity, you cannot exclude anyone that's going to be a potential source of infection. So I do have my concerns in terms of the approach government is taking about getting people to make appointments and then go to a center to be vaccinated. I think just the logistics to implement that, and anyone that has tried to use NATIS online to make a booking for a driver's license will know a system that they've been working on for the past decade still doesn't work. So we shouldn't create problems, and we need to be as inclusive as possible. If we're really serious about getting to the so-called herd immunity threshold, which is what is required to bring an end to the resurgences we're experiencing, it's not going to bring an end to COVID-19. We shouldn't be under any delusions that COVID-19 is going to get away once we get to herd immunity, or 2/3 of the population developing immunity, either by vaccine or natural infection. COVID-19 is going to be with us, probably for decades to come. But what we're trying to avoid when we talk of herd immunity is avoid the types of resurgences that we're currently experiencing. And to be able to achieve that, you need to be as inclusive as possible across all groups of people in South Africa. In terms of pregnant women, the WHO now recommends that based on the risk evaluation, even though we don't have data in terms of safety, but based on risk profiling, if they are at high risk of developing COVID, it's safer the benefit is in their interest to be vaccinated. Because what we've shown in South Africa, in fact, is that pregnant women that develop COVID-19, that increased risk of delivering a preterm baby. So there's consequences in terms of the fetus that they're carrying, and there's good reason to actually protect them. And for children, as Glenda mentioned, those studies are about to start, but even in the United States, it's unlikely children are going to be vaccinated before 2022. I think much of the focus globally, except perhaps in a handful of countries, is going to be focused around ensuring individual benefit foremost, and try to get as high coverage as possible in the community to get that public health value of vaccines to start evolving.
So both of you would agree that there has to be some triaging, there has to be some prioritization. I think our plan is we don't know when the first vaccine is going to get injected into somebody, which is a problem, but we're starting with healthcare workers and then broadening out. what's the thinking behind that, just in a few words? And who should be in that first, who should be first in the line, if you like, for public health reasons? Glenda.
Well, healthcare workers need to be first in line because they're the people that have to take care of people in the health system who have COVID-19. And we've seen a lot of death and morbidity in healthcare workers. Healthcare workers, essential workers, all the people who interface with the public, who are essential and critical to the functioning of our society, need to be first in the queue. So definitely healthcare workers, essential workers, teachers are important, and that they're important for the whole public health benefit. And obviously for individual benefit, it's the elderly, the people with comorbidities, because we want to lessen the burden on the hospital and make sure people aren't dying from COVID in our country. So they're critical as well. So we have to protect certain people, and we have to prevent certain people from dying or getting into hospital. And so those should be the strategy. That should be the strategy. Both protect the workforce and protect the people who are most vulnerable from dying of COVID in our country.
Thanks, Glenda. Shabir, anything from you on that?
Yeah, so the only thing I'm going to add to that, it really depends on what our supply of vaccine is. And I fully endorse that we need to look at healthcare workers and the high-risk groups. But what we shouldn't do is that if we're struggling to get vaccine out, especially to the high-risk groups, we can't have vaccines lying in depots, waiting to develop a strategy to ensure that we get 90% coverage of high-risk groups. It needs to be fluid in terms of its planning, in that if we got large quantities of vaccine, the plan is to get those vaccines out as quickly as possible to as large percentage of proportion of population as is possible. Vaccines don't save lives when they're sitting in depots. Vaccines save lives when you vaccinate people. So we need to be sort of flexible in terms of our approach, and rather having some sort of a notion that we need to vaccinate 80% of people in the phase 2 part of it before we go into phase 3. That is not in the interest of the country. So they really need to be adaptable, and we need to speak to the realities. The importance is to get people vaccinated as quickly as possible while still focusing on those that require it the most as a priority.
Do you think we have the capacity to do that? I mean, I've seen people putting their hands up all over the place. I've seen veterinarians, for example, saying, you know, we know how to inoculate animals. Often veterinarians are the only people in rural areas who can do that. Would you draw in vets? Would you draw in student nurses? Would you draw in occupational health nurses? Do you think that if there was the political will and a plan, that South Africa could reach 67% or whatever it is in a relatively short period of time?
So we need all hands on deck, and we all need to work together. So I do believe that we have tremendous capacity and tremendous ability to do this, but we can only do this if we all work together, and that both the public and the private sector and all disciplines who are able to vaccinate put their hands up and work together. But we do need a system, as Shabir said, that's fluid, that's adaptable, and that is easy to implement. And you don't want to create barrier after barrier to prevent people getting the vaccine. So we have to be nimble, flexible, and we have to use all our resources because they are available.
So Mark, if I just add to that, so there are regulations in South Africa in terms of what category of person can immunize. So as an example, someone that's a veterinarian wouldn't be able to immunize probably humans, depending on what governs their scope of work. So there are some regulations, and it's important to adhere to those regulations rather than trying to rush in. And the reason for that is that for some of these vaccines, you might have what we call a severe anaphylactic reaction. And you need to have the skill set available and the tools available to be able to attend to that. The last thing that we need is for someone to go to a facility to be vaccinated and there's no resuscitation equipment in the vicinity and that person dies. That would backfire. So I think we need to be careful in terms of who we approach to do this. But in terms of the number of people that exist across the public and private sector, there's absolutely no reason for us to actually look for people that are not skilled to do this. Government needs to be clear that the only way this program is going to work in South Africa is, in fact, to a large extent, if it's led by the private sector. The private sector has got a much greater reach, even in the rural areas through general practitioners and through the small pharmacies. They probably got a greater reach than exists in public health facilities. So South Africa is only going to manage to even get 1/3 of the population vaccinated by the end of 2021 if there's a really strong partnership between the public and the private sector.
Thank you very much. Look, I'm worried because I'm watching the minutes run away. I want to say to all the people who are with us tonight that that there will be further webinars on these questions, and that, as I promised at the beginning, we will endeavor to put together a special newsletter to answer as many questions as possible, because there are clearly hundreds of very valid questions, and we only have a couple of minutes left. I want to ask just two quick pertinent questions. One I know is a big topic, and I asked you to, and I wasn't going to deal with it tonight. We'll pick it up another time, but lots of people have asked about ivermectin and its relationship to vaccines. I'd say to those people that it's a critical issue that we are looking at, but I ask Glenda and Shabir if you just want to say just a little bit on that. And then the second thing, I just saw an important question from somebody asking, what do you think about what the UK has done, where they postponed second doses in order to be able to give more first doses to people? Is that advisable? Will we find ourselves in a similar situation here? Just those two questions, and then I'm going to wrap up. Ask the people with us to allow us to perhaps go 2 minutes over time. But Glenda first on those questions.
I'll take the vaccine one. So the longer you wait between a prime and a boost, actually the better is the immune response. And so the period between the two is a good idea. And so from other vaccination programs, we have seen that the spreading out the space between the two vaccines is actually a good strategy, and you'll get a better immune response with the boost in a later phase. So I'm not perturbed by spreading out the vaccines. We see on day 7 after the first vaccine, we already see binding antibodies, and we see the development of neutralizing antibodies, and a boost later will serve the immune response quite well. So I do think it's important to, I don't think that there's a problem, but at the same time, I do think that we need to evaluate the durability and the spacing between the first and second vaccine to make sure that there's not too much waning immunity between dose 1 and dose 2. But I do think the space between vaccines is a good idea. The ivermectin, I think, Shabir, if you want to answer that, I mean, I'll just say I think we need, we need to think of pragmatic study designs that can answer the question very quickly. Because if we don't answer this question quickly and delay it, again, we are missing an opportunity to either establish the efficacy of this intervention or refute it, and that has to be done as quickly as possible with a design that answers the question in a timeous fashion. But Shabir, I don't know if you want to say anything about ivermectin.
Yeah, so just briefly to touch on that, the spacing between the vaccines. The other important reason the UK has gone this direction is that they're in the midst of resurgence. And from the studies from Pfizer, Moderna, as well as AstraZeneca, they actually show protection after a single dose, 14 to 21 days after a single dose. And we don't know what the duration of the protection, but as Glenda pointed out, what you would be able to achieve is vaccinate more people over a shorter period of time, especially when faced with the type of resurgence we're experiencing currently, and then have the benefit of a heightened immune response by delaying the second dose up to about 12 weeks later for the AstraZeneca vaccine, at least. In terms of ivermectin, we just need to be clear, ivermectin is not a prophylaxis. So most of the studies that have been done is in relation to ivermectin being used to treat COVID. There's 1 or 2 small studies that suggest that people can be protected from being infected by a single dose of ivermectin, and by any stretch of the imagination, really difficult to conceptualize, because those drugs are they degraded eventually in the body. So you can't have ivermectin persisting, or its active products persisting in the body for months on end. So in terms of treatment, I think there's probably a study that's going to become available very soon, which will provide probably conclusive evidence as to whether it's suited for treatment or not. Should we be using it immediately? Well, you can argue it either way. People started to use chloroquine, people started to use azithromycin, only to find out that the use of it, in fact, had more severe side effects and didn't have any benefit. So do we want to use something in the absence of robust scientific evidence? I think we're taking a chance if we do so.
Thank you, Shabir, and thank you, Glenda. And to those of you who don't know what ivermectin is that we're talking about, it's an antiparasitic drug for primarily animals, but also for human use. There's been a couple of articles about it in the Daily Maverick recently. It's part of investigation into potential therapeutic drugs that could be added to our armory against COVID-19. Yes, very important to look into, and we may well return to it in a webinar as the further evidence emerges. We're out of time, everybody. Before I say thank you, I just want to say, Glenda or Shabir, do you have any final burning 30-second something that you would like to say to the people who remain with us just after 8 o'clock on Saturday evening? Not Saturday evening, I've forgotten what day it is, but 8 o'clock in the evening.
We need a vaccine, and we need to get our communities, we need to get our family members and our friends to take the vaccine. And I would like to encourage people to receive the vaccine when they can get it, and to encourage their loved ones also to get the vaccine so that we can start to control this epidemic in our country.
Thank you, Glenda. Shabir?
Yeah, so just to echo what Glenda said, if there's any chance of us wanting to get back to a relatively normal lifestyle, the only way to get back to that as soon as possible is by vaccination. There's no other option available to us. So unless we're prepared to continue with resurgences for the next 2 to 3 years, we need to get a large number of people vaccinated with an effective vaccine. The big issue right now is whether these vaccines are going to work against a variant, and we will be able to address that in a matter of weeks. And once we show, hopefully, that it does work, then it really needs to be all systems in place to make sure that we get the vaccines that have been promised to South Africa, and that we have the systems in place to deploy it as quickly as possible so that we can start really saving lives and return to a relatively normal lifestyle.
Thank you both very much. Thank you to your teams that work with you. We look forward to hearing your results in coming weeks. Thank you to Conrad Adender Stiftung, who sponsored this evening's webinar. Thank you to my colleagues at the Daily Maverick who helped put it together for us. And I want to just finish by thanking the healthcare workers again, all the healthcare workers in our country, the nurses, the doctors, the cleaners, the security guards, the people who are weathering this storm for us, and despite all of the difficulties they face on or the risks they face on a day-to-day basis, keep on going back. We admire you, we love you, we respect you, and we will do everything within our power, all of us, on the vaccine, on every other front, to make sure that we save your lives and that we overcome this epidemic in good time. There will be more of these webinars. I give you an assurance that we will try to answer all the unanswered questions that we didn't get to tonight, including the questions about how a rollout takes place, the kind of political questions that have been so controversial. But for tonight, we thought it was important to concentrate on the science whilst we have these two world-class scientists sitting in front of us. So thank you, everybody. Thanks, Glenda and Shabir. Good night. Thank you. Bye-bye.
Thank you.